ورحمة الله. مرحبا دكتور هاني.
وعليكم السلام ورحمة الله وبركاته دكتور ثاني.
وعليكم السلام والرحمة.
عليكم السلام ورحمة الله.
وعليكم السلام.
So always be familiar with all guidelines of resuscitation, whatever adult ALS or pediatric ALS or newborn resuscitation, and the ATLS as well, guidelines. Neonatal sepsis, cyanotic, non-cyanotic congenital heart disease. We discussed this one in cardiology. We will just refresh our knowledge. Jaundice, we are talking about neonatal. So the first months. Okay. Feeding patterns, anything related to pediatric, very, very important, guys. I forgot to tell you also. So you have cardiology, resuscitation, also trauma, anesthesia, and pediatric. 5 chapters, very, very important. So we will talk about cardiac. We will talk about neonatal condition number 1, delivery and resuscitation of the newborn. So assess Apgar score. So here you will follow A, B, C, D, E. A, B, C, D, E. So you will check for appearance, Apgar, appearance, skin color. Appearance here, it will be in airway, breathing, or circulation, guys.
Breathing.
Circulation. Okay. Skin color, circulation. Pulse, circulation, grimace. Okay. So grimace here, reflex irritability. So this one, disability, because it's related to grimace and activity, muscle tone related to disability. Respiration is related to breathing. So once you receive the newborn, you will assess A, B, C, D, E. The airway is patent. For secretion, you will do suction. For breathing, if there is no breathing, you will deal with that. After that, heart rate, if less than 60 or more. And after that, D, disability, muscle tone, and grimace reflex. Also in C, I forgot to tell about appearance and pulse. So according to the score, you will understand this patient low or moderate or high score. So think about 2 points. If the patient pink, so 2 points. Patient pulse over 100. Response to stimulation, active, vigorous crash. So this one, 2 points. And 1 point, the patient pink body, pulse below 100. Response, we are talking about grimace, means response. So it's in disability. Response to stimulation, flexed arms and legs, and respiration slow and irregular. 0 point, if you find any of these. So the appearance here in circulation, blue or pale, pulse absent, floppy, disability, and absent activity, muscle tone, absent respiration. So 0 point. So first of all, you will check antenatal counseling. So team briefing, you will assess, you will introduce yourself to the team. After that, you will confirm ID of the team and the grade. So team briefing, equipment check, prepare equipment for airway, breathing, circulation. Then the birth, once you receive the newborn, so first of all, delay cord clamping. Delay cord clamping. For how long, guys?
At
At
least
least 1 minute.
1 minute.
At least 1 minute, yes.
At least
60
Yeah.
seconds. 60
So-
seconds.
They said delay cord clamping. They did not mention here in the algorithm, but at least 1 minute. If you find 1 minute, it shows 1 minute. So the first action, at each point, it can be a question. The first action, start the clock, no time. Then dry, wrap, stimulate, keep warm. You will dry by 2 towels. 1 towel you will dry and throw. The other towel you will cover the baby to keep warm. Wrap and stimulate. So you will check for a response while you are drying. Assess. You will check color, tone, breathing, heart rate. So A, B, C, D, E. Ensure an open airway. If preterm, consider CPAP. Okay, preterm. So it can be an option in the exam. It can be question. And this one, it can be question. Okay. If gasping, not breathing, so give 5 inflations. So if you find in the scenario, the patient newborn, and he said the patient is gasping, not breathing. What is the next action? 5 inflation will be 30 centimeter water, start in air. Start in air here means without oxygen. So you will give 5 inflation. Inflation here, how many seconds, guys?
30 seconds.
Excellent, 30 seconds. So you will inflate the back valve mask. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. This is inflation. Okay. You will inflate the lung. It's different than ventilation. Ventilation, it will be 1 second. Okay. Inflation, because the lung may be collapsed. The newborn just born now, and maybe the lung collapse. So you will inflate the lung. Okay. Apply PEEP 5 centimeter water if possible. This normal PEEP. Okay. Apply SpO2, ECG. And reassess if no increase in heart rate. So first of all, you will check breathing, as we said. So breathing, if not gasping or not breathing, this is your action. And then you will check heart rate, look for chest movement. So if the chest is not moving, so what you will do can be a question. Check mask, head and jaw position. 2-person support. It means you will do back valve mask the same. 5 inflation again, but this time it will be 2-person support. Did you find here put under bed under the neck, guys? Here?
No.
No.
No. We are doing in newborn resuscitation, even in OSCE we are doing, but here, according to the algorithms, they did not mention. They mention 1-person technique and then 2-person technique. Okay. So just check mask, head and jaw position, 2-person support, consider suction, laryngeal mask, tracheal tube, repeat inflation breath, but this time inflation with 2-person technique. It means I will use 2 hands in mask. I will ask the one responsible for airway to do bagging, inflating. Okay. The same also. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 5 times. Okay. So reassess after that. If no increase in heart rate. What about heart rate, guys? What does it mean? How much?
60.
60. Okay. So even the patient has heart rate 59, so it means you have to resuscitate the baby. Okay. If no increase in heart rate, look for chest movement. Once chest is moving, continue ventilation breath. So if the breathing is compromised, the action is 1% technique. If failed, 2% technique, inflation. This is the action or intervention for breathing. What is the intervention for circulation, for heart rate?
CPR.
CPR.
Ventilation.
Ventilation.
Ventilation. Don't go to CPR now, okay? Again,
Okay.
the action for breathing. If breathing is compromised, how to understand the compromised in the scenario? They will mention gasping or not breathing. So your action, 1% technique, 5 inflation. If not responding, 2% technique, 5 inflation breath. Done. This is your intervention. Regarding circulation, we are talking about heart rate less than 60. It means a compromise. If you find in the scenario, the heart rate is, for example, 59, so it's compromised. It means you will start what?
Ventilation.
Ventilation breaths. How many ventilation breaths?
30.
30. Each ventilation in 1 second.
1
So
second.
how many seconds?
30.
30 seconds. Okay. And you will check heart rate again after 30 seconds. Okay. If heart rate after 30 seconds not detectable or less than 60 after 30 seconds of ventilation, you see? So you will do what?
Chest compression.
CPR.
CPR.
Okay. So ventilation is the first action if circulation is compromised. So this is the first intervention. So if failed ventilation for 30 seconds, you will do CPR. CPR here, synchronize 3 compression to 1 ventilation, 3:1 ratio. Increase
Dr. Hani.
oxygen.
Dr. Hani,
Yeah.
how do you do synchronous 3 chest compression? How do you do?
Again, please.
How do you do synchronize chest compression?
Synchronize 3 compression.
Yeah. Yeah.
It means 3:1 normal ratio, 3:1.
Okay.
Yeah. So here you will increase oxygen to 100. When you are doing inflation with oxygen or with air in breathing?
Without oxygen.
With air.
In air.
With air. They
Atmospheric
said
air.
here in the algorithm with air. Okay. Start in air. So no need for oxygen here. Okay. And here if circulation is compromised, if you will start CPR, so
Sorry, Dr. Hani.
yeah.
Regarding inflation, you mean same mouse to mouse breathe or what?
No, back valve mask.
Back.
Back valve mask.
Back valve mask, okay? So you will inflate the lung, not ventilation, okay? Ventilation, it means the lung is not collapsed, so you will do ventilation. But inflation, the lung is collapsed, you will do inflation, okay? Consider intubation. If not,
Excuse me, Dr. Hani, about the ventilation here. If heart rate not detected or less than 60, I will give
yes,
30 ventilation.
yes, for 30 seconds. If you find this option in the scenario, choose, okay? If they mention in the scenario, the patient given ventilation, 30 ventilation for 30 seconds, and heart rate is not detectable or less than 60, so you will do CPR. And here you will use oxygen, you will increase up to 100%. Consider intubation if not already done, laryngeal mask if not possible. Reassess heart rate after how long?
30 seconds.
So
30 seconds.
ventilation 30 seconds. CPR for how long?
30 seconds.
30 seconds. In adult and pediatric, how long is the cycle?
2 minutes.
2 minutes.
2
So
minutes.
after 2 minutes in ALS or ABLS, stop, switch rules, check rhythm and the pulse. This in OSCE. Again, so 2 minutes passed, stop, switch, check rhythm and the pulse. We are talking about ALS, ABLS. But newborn, for how long? 30 seconds. So stop, switch. So the one for airway, the one for circulation, they will switch rules. So the one for airway will be for circulation, the one for circulation will be for airway. So stop, switch, check the rhythm and the pulse. Here, don't say rhythm and pulse in newborn. You will say stop, switch, check the heart rate. Okay, because maybe the heart rate 50 or 55 or 59. It means you will continue CPR. Okay, so if the heart rate remains not detectable or less than 60, you will continue CPR, but this time with drugs. You will insert vascular access and the drugs. So vascular access here will be
IO.
Umbilical.
okay. So this is the difference between newborn and ALS, ABLS. It will be umbilical. So first action will be ventilation. Second action will be
CPR.
CPR without medication. Third action, CPR with
Medication.
Drugs.
medication. After that, in any CPR, whatever ALS or ABLS or newborn resuscitation, you will consider 4H and 4Ts. What are the 4H, 4Ts? Hypothermia, hypoxia, hypovolemia, and hypokalemia.
Hypothermia,
hypoxia, toxins, and tamponade and thrombose. But here in regarding newborn resuscitation, what are the reversible causes? Pneumothorax, hypovolemia, congenital. We are talking about newborn, congenital abnormality. Okay. If they ask you what are the likely cause in this condition, so if you find pneumothorax, choose hypovolemia, choose congenital abnormality, choose. They put pneumothorax number 1, so this is the most likely. They put hypovolemia number 2, the second likely. They put congenital abnormality number 3, so this is the third likely. Okay. After that, you will update parents. You will talk with the parents and inform them about details. Debrief team. So you start by briefing team, means you will introduce yourself, confirm their ID and the grade or level. After that, you will give them tasks. Okay. Here, the opposite. After you finish, you will debrief team and you will document everything, complete reports. So this is the explanation. Okay. Okay. Regarding cord clamping, after 1 minute, if you find this option in the scenario, choose. Apgar score, so this one simple method of assessing neonates well-being at birth. 5 criteria, each of which is allocated a score between 0 and 2. The assessment is performed at 1 and 5 minutes after delivery and repeated later if the score remains low. Repeated later. So once you see the newborn, you will assess Apgar score. It means at 0 minutes. Okay. And later, after how long, guys?
5 minutes.
5 minutes. Okay. So it means secondary survey. So primary survey and secondary survey. Scores of 7 and above, this is normal. A score 4 to 6, low. A score of 3 and below, so critically low. And this Apgar score. Condition number 2, neonatal sepsis. So how to understand the neonatal sepsis? Sepsis, we discussed the sepsis before, okay? It's clear for you. And in neonates, so any patient with sepsis in neonates, so it's called neonatal sepsis. The most common causative organism, Streptococcus collected. So group B streptococcus, gram-positive cocci, streptococcus pneumonia, gram-positive cocci, Escherichia coli, so gram-negative rods, Listeria monocytogenes, gram-positive rods. What about the treatment in neonatal sepsis? So IV benzyl penicillin with gentamicin is first choice antibiotic for empirical treatment of suspected infection. Remember that, please. We discussed before in infectious disease presentation number 1 regarding fever, and today we will just refresh our knowledge for neonatal condition number 2, neonatal sepsis. So we have to talk about fever. In fever, we discussed in infectious presentation number 1 about traffic light system, and we said this traffic light system up to how many years, guys?
5 years.
Excellent.
5 years.
So this traffic light system up to 5 years. So any patient, whatever one day, up to 5 years, follow the traffic light system. So again, red, amber, green, high risk, intermediate, and low risk. And we discussed before, if the patient has any of these features, so it's red, high risk, appearing ill to health care professional, grunting, pale mottled skin, no response to social cues, doesn't wake, or if roused, doesn't stay awake, weak, high-pitched, or continuous cry, respiratory rate greater than 60, moderate or severe chest and drawing, reduced skin turgor, bulging fontanelle. And amber, if you find any of these features in the scenario, so intermediate risk, pallor of skin, lips, or tongue reported by parent or carer, not responding normally to social cues, no smile, wax only with prolonged stimulation, decreased activity, nasal flaring, dry mucous membrane, poor feeding in infants, reduced urine output, and regurgitation. Green, so low risk. If you find any of these features, it means it's green, and it's unlikely to give you green in the exam. So they can give you amber or red. So if you don't find red, it means it's amber. Green here, strong normal cry or not crying, normal color of skin, lips, and tongue. Respond normally to social cues, content smiles, stay awake or awakens quickly, normal skin and eyes, mucous membrane. So we said how to manage fever. We are talking about fever of unknown source. Unknown source. You don't know why is it pediatric case they have fever. Okay. There is no clear cause. So you have to manage this patient first by investigations, then antibiotic if needed. So we divided 5 years, so less than 3 months and more than 3 months. This is how to manage a fever within 5 years. Less than 3 months, more than 3 months. So our topic today, neonatal sepsis. Less than 3 months or more than 3 months?
Less than 3 months.
So we will talk now about
3 months.
less than 3 months, okay? We discussed before in infectious presentation number 1, but we will talk about neonatal. It means 1 month. So less than 3 months, routine investigations. The patient in the scenario has fever. They did not mention any clue or any source. So you will do full blood count, CRP, blood culture, urine testing for UTI, and chest X-ray if you find any signs of respiratory in the scenario, stool culture if you find diarrhea in the scenario. And lumbar puncture, when to do lumbar puncture less than 3 months. If the patient is younger than 1 month, it's our topic today. So if the patient has fever and neonate, you will do
lumbar puncture.
Clear? So any neonatal fever, you will do lumbar puncture according to the guidelines. What else? Infants age 1 to 3 months who appear unwell or who have white cell count less than 5 or more than 50. So Our talk today, neonatal sepsis, neonatal fever. We are talking about lumbar puncture, whatever, less than 1 month, or the patient 1 to 3 months appear unwell or white cell count less than 5 or more than 50. What about the treatment? Indicated or not indicated? So if infants younger than 1 month, so our topic today, any neonatal fever, you will give
Antibiotic IV.
Okay, so the topic today, you will do all routine investigations. You will do lumbar puncture, you will give antibiotic. I think it's clear now, okay? Infants age 1 to 3 months who appear unwell, or 1 to 3 months who have white cell count less than 5 or more than 50. So the indication of IV antibiotic, the same indication for lumbar puncture. It means if you will do lumbar puncture, it means you will give IV antibiotic. Okay, condition number 3, cyanotic and non-cyanotic. We discussed in the chapter of cardiology. You can go back to cardiology chapter and review, but we will just refresh the most important points. Causes of congenital cyanotic heart disease, it means 5 T's. So tetralogy of Fallot, 4 criteria, tetra. Transposition of great vessels, so aorta and pulmonary, they are replaced, and this patient needs the surgery to replace. Tricuspid atresia, truncus arteriosus, total anomalous pulmonary venous return, Ebstein's anomaly, hypoplastic left heart syndrome. Causes of congenital acyanotic heart disease, so ventricular septal defect, atrial septal defect, or maybe both, atrioventricular septal defect, maybe a problem in the pulmonary or aortic, so pulmonary stenosis or aortic stenosis, also coarctation of aorta, patent ductus arteriosus. So do you remember, guys, here the patient will be pink or blue?
Pink. Blue.
Cyanotic, blue.
And the acyanotic, it will be pink. And here,
Pink.
what is the pathophysiology?
Right to left center.
We have 2 pathophysiology. One is decrease or increase pulmonary hypertension, or so this one, and in congenital acyanotic heart, so it's overload. So the pathophysiology here, overload. Tetralogy of Fallot, so the most common types of congenital cyanotic heart disease. If they will ask you, maybe they will ask you about tetralogy of Fallot, maybe they will ask you about also transposition of great vessels, maybe they will ask you about patent ductus arteriosus. So you can expect tetralogy of Fallot, transposition of great vessels. They can ask you also about patent ductus arteriosus. But anyway, you have to be familiar also with ventricular septal defect, atrial septal defect. So the 4 features of tetralogy of Fallot: pulmonary stenosis, overriding aorta, ventricular septal defect, right ventricular hypertrophy. So they can ask you regarding these features, or they can mention in the scenario and they will ask you about the diagnosis. This is associated with several congenital syndromes. All we are talking about cyanotic or non-cyanotic. So the George syndrome, trisomy, fetal alcohol syndrome, maternal phenylketonuria. Many cases of tetralogy of Fallot are now diagnosed during antenatal screening or detected during early postnatal assessment in the form of heart murmur. Patent ductus arteriosus present at birth provide additional blood flow to the lungs. So severe cyanosis is rare early after birth. When the ductus arteriosus close, typically a few days after birth, cyanosis can develop. In cases that are undetected, the clinical features of tetralogy of Fallot, so the patient will get severe cyanosis, so squatting or knee to chest position. The patient will do like that, trying to compensate. Poor feeding, breathlessness, dyspnea on exertion, hypercyanotic spells precipitated by activity, agitation, developmental delay, failure to sleep. Cardiac examination may reveal the following: loud, long ejection systolic murmur due to pulmonary stenosis, because we said one of the tetralogy of followed features, pulmonary stenosis. So the murmur here will be loud, long ejection systolic murmur, systolic thrill at lower left sternal edge, aortic ejection click, digital clapping. The chest X-ray will be boat-shaped, we discussed before. Definitive management, so surgical repair that usually occurs within the first year. So the X-ray we discussed before. Neonatal condition number 4, jaundice. So neonatal jaundice here, check in the scenario, it's conjugated or unconjugated. Conjugated hyperbilirubinemia, think about pathology, always pathology. But unconjugated, sometimes it's physiological or pathological. Okay, guys? In practice also, if you find one baby with jaundice, check he has conjugated or unconjugated. If conjugated, always pathology. And it means hepatic or post-hepatic.
Post-hepatic.
I think it's clear now. So again, if you find in the scenario, they said the patient has conjugated hyperbilirubinemia, think about hepatic or post-hepatic. As we discussed before, the types of jaundice, 3 types: pre-hepatic, before the liver, intrahepatic, inside the liver, post-hepatic, after the liver. So here in neonatal, if you find conjugated, maybe hepatic or post-hepatic. It means pathology. But unconjugated may be physiological, it means normal, may be pathological. If pathological unconjugated, it means maybe hemolytic or non-hemolytic. So here we will care about conjugated hepatic, post-hepatic, unconjugated hemolytic, non-hemolytic. This is the conclusion. Check the last boxes, okay? So hepatic, post-hepatic, or hemolytic, non-hemolytic. This conjugated, unconjugated. So unconjugated hemolytic and non-hemolytic. Neonatal jaundice can be subdivided into 2 groups, as we said: unconjugated hyperbilirubinemia. As we said, it means maybe pathological or physiological, and it will be hemolytic or non-hemolytic. Conjugated, it will be always pathology, so hepatic or post-hepatic. Jaundice is said to be prolonged if it persists past the first 14 days of life. So if they mention in the scenario, the patient has jaundice for 14 days, is it prolonged or normal?
Prolonged.
14 days normal.
Normal. 14 days normal, okay? But if more than 14 days,
Prolonged.
Prolonged.
hemolytic disease of the newborn. So hemolytic here, we are talking about
Unconjugated.
Unconjugated.
hyperbilirubinemia.
so whatever hemolytic or non-hemolytic, it means un. Okay.
Unconjugated.
If you talk about hepatic, post-hepatic, we are talking
Conjugated.
about conjugate.
Conjugated.
Okay. Okay. Guys, give me 5 minutes, please. Sorry. 5 minutes only. We will take break for 5 minutes only. So, hemolytic disease of the newborn, we are talking about unconjugated hyperbilirubinemia. Type 2 hypersensitivity reaction, cytotoxic hypersensitivity. This is the pathophysiology. Type 2, remember that. Cytotoxic hypersensitivity in the fetus when IgG antibodies from the mother pass through the placenta. That's why we are giving anti-D. So here, if you will not give, the patient will get hemolysis, the patient will get also jaundice. Okay. When IgG antibodies from the mother pass through the placenta. The rhesus gene is made up of 3 parts: C, D, or E. C, D, or E. Maternal anti-D IgG antibodies may form when rhesus positive fetal cells enter the circulation of rhesus negative mother. So this is a pathophysiology. This commonly occurs at delivery, but can also occur after fetal-maternal hemorrhage. So if the pathophysiology happen and at delivery, it can be obvious, but also a fetal-maternal hemorrhage. What does it mean, fetal-maternal hemorrhage? If the patient has a trauma or has any cause for fetal-maternal hemorrhage, and the procedures as well. Other examples of type 2 hypersensitivity reaction, so autoimmune hemolytic anemia, Goodbusher syndrome, myasthenia gravis, rhesus incompatibility. So causes of prolonged unconjugated hyperbilirubinemia. Unconjugated, we are talking about hemolytic or non-hemolytic. Breast milk jaundice, infections, hemolysis, most commonly rhesus hemolytic disease, hypothyroidism, hereditary disorder, galactosemia. So here hereditary like regular Najjar syndrome. So here if the patient has prolonged more than
14 days.
unconjugated hyperbilirubinemia. So unconjugated, we are talking maybe physiological, maybe pathological. Okay, but more than 14 days. So think about, they can ask you which of the following is most likely. If you find breast milk jaundice, choose infections like UTI. Maybe the patient has UTI, that's why he has jaundice. Maybe the patient has hemolysis, like rhesus hemolytic disease. Maybe he has hypothyroidism. Maybe he has syndrome, hereditary syndrome, galactosemia. Cause of prolonged conjugated, we are talking about hepatic or post-hepatic. So maybe something related to the liver or after the liver, like what? Biliary atresia, pseudocalcist, neonatal hepatitis. So whatever hepatic or post-hepatic. Clinical features, failure to thrill, easy bruising, bleeding tendency, dark urine, pale, Schalke stones. So this slide gives you the differential diagnosis. Now, what do you think, guys? Hemolytic, non-hemolytic. So what is the type?
Both are unconjugated hyperbilirubinemia.
Yes, and the hepatic post-hepatic is
Both conjugated.
conjugated. Okay, so hemolytic unconjugated hyperbilirubinemia, you find in the scenario or in practice in real life, you find unconjugated hyperbilirubinemia. So you can think about intrinsic causes of hemolysis. If you suspect the hemolysis, so maybe hereditary spherocytosis, G6PD deficiency. Maybe the patient has sickle cell disease, pyruvate kinase deficiency. So we are talking about intrinsic. It means something inside the baby. Extrinsic, hemolytic disease of the newborn or rhesus disease. Okay. So intrinsic inside the blood. Non-hemolytic unconjugated hyperbilirubinemia. So as we said before, breast milk jaundice, polycythemia, infection, Gilbert syndrome, hepatic conjugated hyperbilirubinemia. So maybe something related to the liver, hepatitis A and B, galactosemia, alpha-1 antitrypsin deficiency, drugs. Post-hepatic, so something related to after the liver, biliary atresia, bile duct obstruction, critical cyst. Regarding biliary atresia, so the evaluation of conjugated hyperbilirubinemia should include ultrasound of bile ducts and gallbladder. Dilatation is consistent with presence of critical cyst and should be further investigated with cholangiogram. If the bile ducts and the gallbladder appear normal or not visualized, so you will do radionuclide scan. The absence of excretion is consistent with biliary atresia. Biliary atresia is caused by progressive destruction or absence of extrahepatic biliary tree and intrahepatic biliary ducts. It's rare, 1 to 10 or 15,000 live births in the Western world. Babies are generally jaundiced early, and their stools are pale, urine dark from the second day of life. So if you find in the scenario, the patient has jaundice in the second day, think about biliary atresia. If you find stool are pale and urine is dark, so think about biliary atresia. If untreated, the condition will progress to chronic liver failure, so it's dangerous, rare and dangerous. Chronic liver failure, with the baby developing portal hypertension, hepatosplenomegaly, and without treatment, death. So what about the treatment? Kasai procedure, remember that. Bile ducts lying outside the liver are removed, and the small intestine is then attached to the liver. This allows bile to drain from the liver. So the problem here in excretion, we said absence of excretion, so you will correct that by this procedure. Good prognosis depends on the surgery being performed early, ideally within the first 2 months of life. Even if the surgery is successful, the child will likely go to liver transplant in the future. Kernicterus, so it's clinical features of acute or chronic bilirubin encephalopathy, the pathological findings of deep yellow staining in the brain. So this is the meaning of kernicterus. Risk factors of kernicterus. So how to understand this patient will get risk factor, it means he will get kernicterus. How you understand this patient will get maybe tomorrow, after 1 week, symptoms of acute or chronic bilirubin encephalopathy. It means the patient has bilirubin now, but maybe after 1 day or 2 days or whatever, he will get encephalopathy. Okay, and also deep yellowing staining in the brain. So we are talking about kernicterus. So if you find any of these in the scenario or in practice, so you should avoid kernicterus. So what are these factors? Serum bilirubin level greater than 340 means this patient high risk for kernicterus. In babies with gestational age of 37 weeks or more, rapidly rising bilirubin level or greater than 8.5 micromole per liter per hour. Okay. So if you find in the scenario bilirubin level greater than 8.5 or rapidly rising, clinical features of acute bilirubin encephalopathy. The most common cause of jaundice in newborn is physiological jaundice. It can be a question. So most neonates with jaundice they are physiological. It means normal, most. Physiological jaundice appears at 2 days of age, peak on day 3 to 5, then decrease usually by around day 10. Risk factors for significant hyperbilirubinemia. So we said here hyperbilirubinemia. So what are the risk factors? If gestational age under 38 weeks, previous sibling with neonatal jaundice. So if the baby less than 38 weeks, it's a high risk for hyperbilirubinemia. If he has sibling with the same problem, so he has high risk to do so. Visible jaundice in the first 24 hours of life. It means this patient, maybe he will get hyperbilirubinemia. Mother's intention to breastfeed exclusively. Visible bruising, dehydration, male, maternal age older than 25 years of age, maternal diabetes mellitus, Asian, European, Native American ethnicity. Jaundice presenting in the first 24 hours of life is more likely to have serious underlying cause. So any jaundice in the first day, think about infection, hemolytic disease, metabolic disorder. Any baby presenting with jaundice in the first 24 hours, seen urgently for assessment in hospital. Hence, bodies are clumps of damaged hemoglobin located on red blood cells in hemolytic anemia. So how to diagnose hemolytic anemia? You will find hence bodies. So it's damaged hemoglobin. What about G6PD deficiency? Familial enzyme disorder of red blood cells. Condition number 5 and the last one, then we will go for questions. Feeding better. What do you think regarding this condition, guys? Feeding better in neonate. What does it mean?
Hypertrophic pyloric stenosis.
Pyloric stenosis.
So patient neonate and with feeding problem, think about hypertrophic pyloric stenosis until proven otherwise in the exam or in practice. Diffuse hypertrophy, hyperplasia, smooth muscle of the antrum of stomach, narrowing of pyloric canal, easily obstructed. 1 in 500 live births. So it's very rare. Male to female, 4 to 1. So we will find in the scenario, male. Firstborn, male children, believed to have the highest risk. Olive shaped in the scenario, palpable in the right upper quadrant or epigastrium, 95% of cases. The typical acid-based disturbance because of vomiting. This vomiting, guys, will be bilious or non-bilious?
Non-bilious.
Non-bilious.
So vomiting here, it means hypochloremic metabolic alkalosis. We discussed it in previous chapter. Due to loss of hydrogen and chloride ions in the vomitus, decreased secretion of pancreatic bicarbonate. Hyponatremia, hypokalemia present. So if they said in the scenario hyponatremia, choose. If they said hypokalemia, choose. If they said hypochloremic metabolic alkalosis, if you find an option like that, it choose. The principal clinical feature of infantile hypertrophic pyloric stenosis is vomiting. If you don't find vomiting in the scenario, it's not hypertrophic pyloric stenosis. Onset of vomiting, 2 to 8 weeks of age. So we will find the age in the scenario, maybe 2 weeks, maybe 8 weeks, or maybe in between. Vomiting is non-bilious. If they did not mention the type of the vomiting, so exclude or unlikely, don't exclude, unlikely. Okay. Typically projectile. Projectile, it means the vomiting after 1 meter, after 2 meters. The baby is vomiting for long distance. Vomiting usually occurs 30 to 60 minutes post-feeding. It will be in the scenario. So if they find the scenario is describing the vomiting, giving you details regarding the vomiting, so it's supporting the diagnosis. The baby usually remains hungry after the vomiting, persistent hunger. Occasionally, hematemesis occurs. Dehydration, weight loss, constipation. So the investigation of choice, ultrasound scanning, which is both reliable and easy to perform. This has now replaced barium studies as the investigation of choice. Replaced. Okay, so the investigation of choice now.
Ultrasound.
Ultrasound.
Initial management, fluid resuscitation. If they ask you what is the initial management, different is that what is the definitive management? Okay, so the same scenario but different task. So according to the task, you will choose option. So initial management here, fluid resuscitation, correct electrolyte imbalance, and definitive management, surgical. So Ramstead pyloromyotomy. Also laparoscopic pyloromyotomy. So we discussed before the difference between intussusception and pyloric stenosis. So the difference here in pyloric stenosis, 2 to 4 weeks, non-bilious vomiting after feeding, poor weight gain, constipation, or symptoms of volume depletion. Like he will mention in the scenario, decreased with nerve, palpation of olive-shaped upper abdominal mass in the big extreme and right upper quadrant, hypochloremia, hypokalemia, hyponatremia. So investigation, UNE, any surgery case, UNE, VBG, chest X-ray, abdominal X-ray, abdominal ultrasound. The definitive treatment from state pyloromyotomy, and here regarding intussusception, it will be different. It will be 2 to 8 months. Regarding vomiting, bilious, the patient unwell. Same investigations, but here the investigation of a choice is
Air fluid enema.
Air fluid enema.
fluid enema. If they said what is the investigation of a choice in ER, so it can be abdomen ultrasound. But investigation of a choice in general, air fluid enema. It's a therapeutic and
Diagnostic.
and the treatment will be fluid and refer to surgery. So they can give you ultrasound. This is the stomach, and this the sickness, hypertrophy of the canal, and this sign. What is this sign?
Target sign.
Target sign. So this one intussusception, and this one pyloric stenosis.
Dr.
Okay.
Hani,
Yeah.
please, before you go, the age of the, the second, I think, slides of the pyloric stenosis, you mentioned that is 2 to 8 months, and the other one is 2 to 8 weeks, and the other one is 2 to 4 months. I'm sorry, 2 to.
Regarding intussusception, it's months.
No, the previous one.
Weeks.
2 to 4 weeks, and the previous one 2 to 8 weeks.
Yes. So
No,
2 to
the
4
previous-
weeks, it
previous.
means 1 month.
The previous one, the first one. If you go back, please, again. One more. The pyloric, the first one. The age is 2 to 8 weeks here down. Onset of vomiting 2 to 8 weeks of age.
Yeah, it's different from source to source. Okay.
So which one? Yeah.
The most important, the vomiting. The most important, the onset of vomiting. The most important, the patient well or unwell. Okay. But here, regarding, they will give you something obvious. For example, they will mention week in the scenario, and in intussusception, they will mention months. Okay.
Okay.
It will be obvious. Don't worry. They will not confuse you regarding the age. It will be very obvious.
Okay.
So pyloric stenosis, maybe they will give you 2 weeks. In intussusception, 2 months. Okay.
Yes, okay, كده تمام.
Yeah,
That's
don't
good.
worry. Always they are clear. They are, if they will give you a clue for hypertension, they will give you, for example, 200 over 100, something like that.
Mm.
If they want to show you hypotension, they will give you 70 over 30, for example. Clear?
Mm. Mm.
Yeah.
Okay. Thank you.
What is the neonate's Apgar score at 1 minute?
Five.
Okay.
5.
When should the next Apgar assessment be made?
5 minutes.
5 minutes.
5 minutes after
Minutes
the
after
delivery.
What is the neonate's Apgar score at 1 minute?
2, 1.
8.
Okay. What's the next management step? So you have tried, warmed and stimulated the
Ventilation.
baby, placed him in
Ventilation for
neutral
30
position.
seconds.
The baby is not breathing. So
Number two.
the compromise here.
Continue the ventilation for 30 seconds and reassess.
Yeah. So the compromise here is
Breathing. Not breathing.
for breathing inflation. So 1% technique. He said you give 5 inflation breaths and see chest movement. After that, he said no heart rate. So our task here,
C.
C.
Circulation.
circulation compromise. So what is the intervention for circulation?
Continue to ventilate
Do
for
the
30
ventilation for 30 seconds and then
So if the breathing is compromised, you have 2 interventions. First one, 5 inflation breaths, 1% technique. Failed, 2% technique. 5 inflation breaths, 2% technique. Regarding heart rate, means the circulation compromised. You have 3 interventions. First one, ventilate for 30 seconds. The second one is
CPR.
CPR.
Chest compression.
CPR without medication.
Without. Yes.
The third intervention is
Medication.
With medication.
excellent, guys. Which feature is not part of Apgar score?
Oxygen saturation.
Oxygen saturation.
Excellent. First management step for this baby.
Warming, drying, and
Main
stimulation.
train and stimulation. First option.
Okay, so this the steps. You have to check the steps. What is the recommended compression to ventilation?
3 to 1.
3
First option.
to 1. 3 to 1. Baby is not breathing and no heart rate recorded.
5 inhalation.
5
5
inhalation
inhalation
breaths.
breaths.
Option B.
B.
Okay. He said the baby is not breathing, no heart rate is recorded. So here you will manage breathing or heart rate?
Breathing.
You will manage breathing. or
Breathing.
circulation?
First breathing.
Breathing.
Excellent. So first breathing. Okay. So first action breathing, 5 inflation breaths. Whatever, 1% technique or 2%
technique.
Most neonatal deliveries that require resuscitation are corrected by which of the following management steps?
Warming, drying, and stimulation.
Yes.
Option
What is the neonatal Apgar score at 1 minute?
4.
Single most likely causative organism, neonatal pneumonia.
E. coli.
Streptococcus.
It is E. coli.
Okay. Most likely causative pathogen, gram-negative rods.
Group B streptococcus.
E. coli. E. coli.
Oh, gram-negative rods. Gram-negative rods. Yeah.
Most likely causative organism,
Group B.
It is group B.
Group B streptococcus.
Neonatal.
most appropriate treatment,
Number
Is it
It is
penicillin and
benzylpenicillin and
Option 4.
yes. So the baby is less than 1 month,
5 day.
less than 1 month. I don't care about 5 days or 4 days or 10 days. It's less than 1 month, right?
Yes.
Yeah. So less than 1 month indication for lumbar puncture and
IV antibiotic, penicillin, and gentamicin.
Yes, remember that. Your examination is otherwise normal. What is the most likely diagnosis?
Sepsis.
Sepsis.
3 days.
Yeah,
3 days. It
sepsis.
means the neonate, and he was born by normal vaginal delivery. Mother and baby were discharged after 24 hours. Observation.
Yeah.
So 145.
Hypothermic, yes.
It's more than 90. RR high, and temperature is low or high.
Low.
No.
So you think about sepsis until proven otherwise, and it's a neonate, so neonatal sepsis. Which of the following congenital syndrome is most likely to be
Trisomy
present?
21.
Number 2.
Yes. Option 2.
What is the diagnosis?
Boot shape.
Tetralogy of Fallot.
Tetralogy of Fallot.
Okay.
Option 2.
Following congenital syndromes most likely to be present?
George number 1.
George syndrome.
George.
Single most likely diagnosis?
Tetralogy of Fallot.
Tetralogy of Fallot.
Okay. Note a feature of tetralogy of Fallot.
Left ventricular
Left ventricular hypertrophy.
Last one, yeah.
Right ventricular
Excellent.
hypertrophy.
Which of the following increase the systemic vascular resistance?
Squatting.
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 Okay.
Yes.
Following diagnosis cause of congenital cyanotic heart disease?
Tricuspid atresia.
Tricuspid atresia.
Hypersensitivity in jaundice?
Type 2.
Type 2 hypersensitivity.
Anaphylaxis?
Type 1.
Type 1.
2.
No, we are talking about anaphylaxis, not jaundice.
Type 1.
Type 1. Type 1 is anaphylaxis.
Single most likely diagnosis?
Biliary atresia. Yes, biliary atresia. Biliary atresia.
Dark colored
Biliary
urines
atresia.
and dark.
Dark urine and pale.
So he said
stools.
24 day means neonate. He has been feeding poorly, vomiting after most feeds, Deborah stained with dark urine, stools, pale and chalky. So it's a biliary atresia till proven otherwise. Bruises, it's specific also in his arms and legs. Midwife has organized a Hale prick test, revealed total serum bilirubin 208, so it's high, and conjugated. Okay, so conjugated. Do you remember? It's we will refresh.
Conjugated.
Hepatic or post-hepatic.
Hepatic.
Unconjugated
Hepatic or post-hepatic.
Hepatic or post-hepatic.
and conjugated.
Hemolytic, non-hemolytic.
Yes.
Hemolytic or non-hemolytic.
Pre-hepatic.
Pre-hepatic.
Unconjugated.
Pre-hepatic.
Unconjugated pre-hepatic.
Excellent. Which of the following is the single most likely diagnosis? Underlying cause is thought to be intrinsic
Sickle cell.
hemolysis.
Sickle cell disease.
Okay. Hemolytic disease of the newborn
IgG.
is mediated.
IgG. Option 4.
Single most likely diagnosis, intrinsic hemolysis.
Hemolytic. This is again.
Sickle cell.
Sickle
Okay,
cell.
repeated question.
Yes.
Extrinsic hemolytic.
Hemolytic disease of the newborn.
Disease of the newborn.
Hemolytic disease.
Underlying cause is thought to be hepatic.
Alpha-1 antitrypsin.
Alpha-1 antitrypsin
Alpha-1
deficiency.
antitrypsin.
Alpha-1 antitrypsin deficiency. Complication is most
Kernicterus.
Kernicterus.
Okay. Most common cause of jaundice.
Physiological jaundice.
Most likely to be physiological in term infant.
Option B.
I think serum bilirubin level increasing
Option
more
B.
than 5 mg per day.
Yes. Typical.
Serum bilirubin level increasing less than 5. Okay. Which of the following is a risk factor for neonatal jaundice?
Prematurity.
Maternal age.
Okay. Which of the following feature is most concerning in patient with neonatal jaundice?
Appearing within
24 hours.
24 hours.
24 hours.
Neonatal team perform a blood film So
G6PD deficiency.
Okay. Single most likely diagnosis: newborn, postnatal home visit, jaundice.
I think
Alpha-1 antitrypsin.
Number 2. Repeat it again.
deficiency.
Okay. Single most likely diagnosis:
Infantile hypertrophic
She must
Infantile
infant
hypertrophic pyloric
hypertrophic pyloric
yes, 3 week and projectile
vomiting.
Yes.
projectile vomiting.
And palpate olive
And also olive sized mass.
Olive sized mass in the abdomen.
Yes, olive size. 4 weeks.
Same.
Pyloromyopathy.
Number 5.
Number 5. Ramsey pylori.
5.
Metabolic picture:
Hypochloremic metabolic alkalosis.
Metabolic alkalosis.
Number
Metabolic alkalosis.
Metabolic alkalosis.
Metabolic
Number 5.
alkalosis.
E.
Yes.
initial investigation.
Abdominal
Ultrasound.
Ultrasound.
Thank you, guys. So
Welcome, Dr.
inshallah, tomorrow I will do for the next decision. Okay. I will post in the group, inshallah. Bye, guys.
Thank you.
Thank you, sir.
Bye.